Welcome back to Open Med School. I am Dr. Andrews, Professor of Medicine, Consultant Neurologist. Today I'll be discussing on hepatic encephalopathy, an MCQ-based discussion. We'll start with a case. Say a 52-year-old man with decompensated cirrhosis, alcoholic. He has developed a confusion for the last 2 days. There is a inversion of sleep rhythm, that is, he is sleeping during daytime and awake at night. History of GA bleed 4 days ago. On examination, he is disoriented and has got asterixis, slurred speech, and ascites. Question is, what is your most likely diagnosis? Well, I request all of you to take a bit of paper and write down the answer. So what is the most likely diagnosis? Is a Wernicke's encephalopathy. Very unlikely, because Wernicke's encephalopathy presents with the triad of mental changes, ataxia, and ophthalmoplegia. So, alcohol withdrawal delirium, it usually occurs with the tremulousness, hallucinations, and behavioral abnormalities around 72 hours after the stopping of alcohol. So, Wilson's disease, again, this is not the typical presentation of a Wilson disease. So, the patient has got a hepatic encephalopathy called classified as overt hepatic encephalopathy. So, what are the salient points by which you make a conclusion? The patient has got neuropsychiatric symptoms like disorientation, inversion of sleep rhythm, that is, sleep-wake cycle is inverted, and definitely has got asterixis. These are classic signs of overt hepatic encephalopathy as per definition of International Study on Hepatic Encephalopathy and Nitrogen Metabolism. So, asterixis, you can say this patient has got a definite overt hepatic encephalopathy. Wernicke is unlikely, which I have already discussed. Now we go to the next. Once the patient has got hepatic encephalopathy, severity is assessed by grading. So, which grade the patient has got? What's the correct answer? Patient has got asterixis. Asterixis usually occurs in grade 2 and can be present in grade 3 also. So, the patient has got the answer is grade 2 hepatic encephalopathy. According to the West Haven criteria, which is used for classifying hepatic encephalopathy, grade 1 is mild confusion, insomnia, and inversion of sleep rhythm. These are the features of a grade 1. Grade 2, lethargy, some confusion, asterixis. In this patient, there is asterixis. In grade 3, there is more marked confusion, asterixis can be there, and grade 4, there is coma. So, definitely this patient has got a grade 2 hepatic encephalopathy. So, whenever you get hepatic encephalopathy, try to grade the encephalopathy. There are a number of precipitating factors for hepatic encephalopathy. So, let us see what is the most likely precipitating cause. Constipation, there is no history. Constipation, of course, can produce. Infection can produce. Here, the correct answer is patient has got 4 days back GA bleed. High protein diet, all these can lead on to hepatic encephalopathy. So, one of the most important cause for precipitation of hepatic encephalopathy is upper GA bleed. So, you have to look for, ask for history of upper GA bleed. Along with this, you should think about infections, electrolyte imbalance, especially hypokalemia, drugs, especially sedative overdose, and constipation. Here the patient has got upper GA bleed 4 days back, and the time is consistent. So we go to what is a pathogenesis. There are different mechanisms. First and foremost, there is a photosystemic shunting. So the nitrogenous waste, other toxic products coming from the gastrointestinal tract through the portal system to the liver cannot be metabolized. Cytokines, it will be released into the systemic circulation. Including produces inflammation. So that is number one cause. Second is there is increased production of, or there is a hyperammonemia. Third, there is impaired renal function can occur. That one also interfere with the excretion of the ammonia. So we look into our patient. What's the most likely here? The most likely cause is hyperammonemia. So the definite proved thing in the precipitation or the development of hepatic encephalopathy is hyperammonemia. So gut-derived ammonia, that is from the gastrointestinal tract, either from the enterocytes, from the conversion of glutamine to glutamate, or by action of the bacteria on the nitrogenous material, ammonia is formed. This ammonia normally it enters the liver, where it goes into the urea cycle, or it may be used for synthesis of glutamine. When the liver is not functional, what happens? This ammonia enters the systemic circulation. It reaches the brain. In the astrocyte, the ammonia will combine with the glutamate to form glutamine. Glutamine will act as an osmotic agent. It put in the glial cells. This will produce osmotic effect and it will produce rise in intracranial tension due to cerebral edema. In addition, this glutamine can enter the GABAergic neurons where it can be converted to GABA. So one of the things that occurs in hepatic encephalopathy is increased GABAergic action. So in different ways, the basic thing that you remember is hyperammonemia. And hyperammonemia is ammonia is from the gastrointestinal tract that is reaching, not metabolized and entering via the photosystemic circulation for shunting into the nervous system, acting as on an osmotic basis and also as various neurotransmitters, changes in the neurotransmitters. Again, remember that the kidneys also help in excreting the ammonia. When the liver is not functioning properly, the kidney excretes the ammonia. And along with the liver failure, there can be renal failure also. This will again contribute to hyperammonemia. Hope this point is clear to you. Now we go to next question. Many of the hepatic diseases, there is sarcopenia, that is the muscle comes down. So we look into the next question. Why does muscle wasting worsens hepatic encephalopathy? This is the wrong answer. Muscle help to clear the ammonia. So remember this point, a patient who is wasted and sarcopenia is there are at increased risk of development of hepatic encephalopathy. So remember this point, muscle removes ammonia, sarcopenia increase the chance of hepatic encephalopathy. So skeletal muscle is a major extrahepatic site of ammonia detoxification. It converts ammonia into glutamine. So that's another point to remember, that is the already I have mentioned plus glutamate. Get the ATP, you get glutamine. So this conversion, sarcopenia reduces this capacity, worsens hyperammonemia and higher risk of hepatic encephalopathy. So now we go to the examination. I already mentioned the higher mental function changes. Inversion in sleep rhythm is one of the early manifestations. The most important physical sign that you look for is, of course, in the common class, the grade 4, you may get a Babinski sign. Asterixis is the classical finding. So what is asterixis? This is the inability to maintain sustained posture of an outstretched extremities. So you keep the hands like this. So unable to maintain the posture, so what the hands will go like this. So it's actually not a positive phenomenon, it is a negative myoclonus. It is unable to maintain the posture, so the hand goes like this. So this is a negative myoclonus. There are different causes for myoclonus, but in a liver disease setting, remember, this is one of the important point to remember. Ascites is otherwise called a liver flap. It can occur in renal failure, certain drugs can produce, or so it is not a thagnomonic sign of hepatic encephalopathy. The posturing, etc., will occur, can occur. So seizures can occur, decerebral posturing can occur. But the correct answer for hepatic encephalopathy bedside testing is, the hallmark is clapping tremor. Now go to the laboratory findings. What's the most useful test? We already discussed ammonia is the most important. Ammonia, hyperammonemia. And the hepatic encephalopathy depends upon the amount of ammonia. Higher the ammonia level, more is the likely chance. Now we have said about the overt hepatic encephalopathy. So what is meant by overt hepatic encephalopathy? So what is true? Always symptomatic includes this. There is another terminology, covert hepatic encephalopathy versus over. So covert includes minimal and grade 1. Grade 2 onwards, you call it as the covert hepatic failure. So covert hepatic encephalopathy, subtle changes affects daily function. That is the covert hepatic encephalopathy. So these two terms. So the ISHN defines covert hepatic encephalopathy as minimal grade plus grade 1. Distinction is subtle. Detected with psychometric testing sometimes. Covert hepatic encephalopathy does impact the quality of life, work performance, driving ability, and risk of fall. So this is the new term. Now we go to the contributors, which does not contribute to hyperammonemia. Hyperglycemia is not. The shunt can contribute. Sarcopenia can contribute. Colonic bacteria can contribute. So autosystemic shunt, bacterial urease activity, and sarcopenia all contribute. Hyperglycemia is not a contributor. So this is a multiple response. Now, what is the first line management? Sedative should not be given. High protein diet is not a treatment. Treat the precipitating factors. Start lactase. These are the two initial management steps. So first step is correct the precipitating factors like bleeding, infection, electrolyte imbalance, overuse of diuretics, if a large volume paracentesis has been done. So all these should be looked for. Start ammonia lowering drug, that is lactulose. Protein restriction is outdated. Adequate protein intake is essential. Sedatives should be avoided. Now look into what is the mechanism of action of lactulose. Lactulose is a disaccharide. So lactose, but is not affected by the intestinal enzymes. So what happens? It reaches the colon. Colon is acted upon by bacteria fermentation. It forms organic acids. It decreases the pH. Hydrogen ions are there. It combines with the ammonia to form ammonium NH4, which cannot be absorbed, and so it is excreted. So that is the basic. In addition, because of the osmotic effect, prevents constipation and clearing of bowel. Laxative action, plus it helped in converting the ammonia into ammonium, and it will not be getting absorbed. So today's take-home points are: hepatic encephalopathy is a neuropsychiatric dysfunction due to liver failure, and base is the portosystemic shunting. It is classified into covert and overt. Overt is encephalopathy 2 to 4. 1 and grade 1 is, or minimal changes are, overt. Hyperammonemia is central. In addition, inflammatory cytokines, sarcopenia, renal dysfunction also contributes. The major precipitating factors are upper GI bleed, infection, constipation, dehydration, large volume paracentesis, hypokalemia, bedside clues, asterixis, and the reversal of sleep pattern. Treatment is: treat the precipitating factor, start on ammonia lowering drugs, lactulose, and antibacterials like rifaximin, because bacteria contribute. Hope this was useful to you. Stay tuned for further sessions. Thank you.